Here. Okay, ready? Can you guys see this? Are we live? Anybody got the Zoom going? No? All right, it should work.
Do you want us to be seeing the camera view behind Ian?
You guys see that at home?
Yeah, I'm gonna give you a thumbs up.
I'm on the first slide. Okay. So pediatric GI, all right?
Yeah, can you move then?
Oh, sure. Gosh, you guys just want everything. All right. Let's see. Bear with me. Slideshow. Come on. How about this thing? Weird. Okay. I must have switched screens or something. Damn. Oh, wait, let's try this thing. So you guys are going to see that right now? Why won't it do it for me? It's doing it over on this screen.
You drag it over.
I tried.
Do it from there. That's good enough.
Okay. Can you see that? Okay. All right. Well, people at home will have a better view. That's just pisser. Okay. Well, I won't do this then. Okay. Nope. Okay. So pediatric GI disorders. Big thing here, you want to take a really good history and physical exam. You need to start screening right here during your HPI is when you want to start thinking of differentials, okay? So on your SOAP notes, I'm sure you guys are getting sick of me saying you better define your patient in the first sentence. So I want to know, is a 3-year-old male? Great, good job, 2 points. But does this male have cancer? Is he a normal, healthy child? Is he up to date on his vaccinations? Because those are 2 completely different children, right? And then you also want to start documenting and asking about PO intake, okay? When do kids get sick? When they stop eating, okay? That is the key history for kids. Now, parents will always say, my child is not eating. You need to define that, because if you winnow that down a little bit, they'll say, well, yeah, he's eating about half, okay? That's not as concerning as 0, okay? When kids get really sick as stink, they quit eating, okay? That's a dangerous kid. But a kid that's eating about half and has nasal congestion, you ever try to drink a beer with your nose plugged? It doesn't work, okay? Carly has, we know that. All right, so there are some GI manifestations of cystic fibrosis, which we'll talk about. We need to be able to differentiate between urgent surgical diagnoses and less urgent. And then we'll talk about acute gastroenteritis and differentiate that from other infections, and also how to guard yourself in documentation. So the history. So you want to know where the abdominal pain is, how long it's been going on, if there's associated vomiting and diarrhea. So why do I care if there's vomiting and diarrhea? That's true. The really reason I care is because it makes me think that it's probably gastroenteritis. If you have vomiting and then you start having diarrhea, you most likely 99 times out of 100 have simple gastroenteritis. If you have vomiting without diarrhea, you can't put your finger on it. If you have diarrhea without vomiting, you can't put your finger on it, okay? If it's vomiting, you can suspect early onset gastroenteritis, but you could be fooled. So GI bleeding, obviously that's a big deal. That black tarry stool is more concerning than bright red bleeding, unless you're talking about current jelly stools, which we'll talk about in a little bit. What else do we want to know?
Vaccines, like you said.
Mm-hmm.
Where's
Exactly. So are they up to date on their vaccines? Are they eating or drinking? Any signs of dehydration? Is this a healthy child, or does this child have some underlying medical issues? So physical exam, vital signs. They are called vital for a reason, okay? These are going to tell us if we have a sick kid or a not sick kid. Make sure that those vital signs are documented correctly, okay? If I have a child that's breathing at 18 breaths per minute, that's a problem, okay? Somebody just decided to put 18 because that's what they put for all adults. So go back and check that respiration check, go check those respirations, and then go back to your nurse and say, hey, can you redocument those respirations? Because this kid's actually breathing at 24 beats per minute or breaths per minute, and, you know, have a little conversation there. What's their mental status? Okay, a confused kid is a lot more disturbing than a normal child that's not confused. If the child's playing with color crayons and playing with toys in the room, that's a lot less concerning. What does their skin look like? Heart and lung exam, obviously, and then a good abdominal exam. So things that you're going to be looking for here. I mean, you want to know, is this respiratory distress or is this abdominal distress? What type of a child are we dealing with? There's just a lot of things that you can see on physical exam. Your real take home is this a sick kid or a not a sick kid? Do I follow the nurse into the room, or do I just sit here and finish a couple charts and then go check that kid out? All right, so chief complaint of abdominal pain, right? So most chronic and recurrent abdominal pains, and some are acute functional abdominal pain. So there's going to be these children that kind of have this underlying chronic abdominal pain, and then there may be some that have recurrent abdominal pain. Is this new? Have they had a history of this before? What type of pain are we dealing with? Okay. We want to make sure that we're ruling out any of the red flags, and we'll talk about these red flags here in a minute. And then we want to limit any unnecessary evaluations. So let's talk about that. That's really important. And that's really when you start to practice medicine, you start to be a little more comfortable, let things go a little bit. So like I was at Trios on Saturday, and I had a little girl that came in with generalized suprapubic abdominal pain, cramping, and vomiting. Okay. So that could be everything from an appendicitis to a bowel obstruction to simple gastroenteritis. So, or a urinary tract infection. So the first thing we did was a urinary workup on her. So she just did like a simple UA. The UA came out clean, which I was surprised because I thought this is a straightforward UTI. So then that made it a little bit more concerning, right? She'd had 6 episodes of vomiting that day, but her vital signs looked good. Her physical exam was good. She was a healthy 6-year-old child with no other chronic medical problems. So then the question is, do you poke them? Do you do the big workup? And then eventually you're going to get yourself an ultrasound and maybe a CT with contrast. So I just went in and sat down. I re-examined her. I pushed on her right lower quadrant. I did the psoas sign, the obturator sign. I had her stand up and hop on her right foot. No pain anywhere. She corrected with Zofran. I sat down and I talked to her dad. I said, look, we can do labs. We can do $1 million workup, or we can give her a little Zofran, go home. If it's something big, she's going to get worse. If it's not, she'll probably get better. If you told me she had diarrhea, I'd feel a lot better about it, but I don't know right now exactly what's going on. I think it's a simple stomach bug, but I'm not really sure. So you can have that conversation with the parent, give them really good return to care precautions, and then document that. And that's an acceptable course of action. When I first started, I probably wouldn't have done that. But after a while, you get a little more comfortable, you start seeing a lot of this stuff, and then you can do that. So what makes you more concerned, right? So there's some symptom-based diagnoses that you can perform. You want to basically rule out pathology by their symptoms. You know, how long does the pain last? So if there are these colicky bouts of abdominal pain that last less than 5 minutes, that's a little less concerning. If they're waking them up at night or they're inhibiting them from doing their normal activities, that's a little bit more concerning. And we want to identify the location, okay? So as we look at a belly, we're thinking of what are the underlying structures of the belly. If you really want to get crazy, go to Pacific Northwest and check out the book called The Acute Abdomen. It's a blue book. It's about that thick. It's a good read. I read it when I was in school, and it's probably the best book about working up undifferentiated abdominal pain. Maybe get it for your Christmas break. All right, so functional abdominal pain. What the heck is functional abdominal pain? So functional abdominal pain is just this colicky type abdominal pain. They are going to have normal growth, normal vital signs, and minimal distress. So although they're grading this pain as 9 out of 10, they're not tachycardic, they're not sick, and they're afebrile. They're growing normal, and they don't really look sick on physical exam. They're just telling you it's a 9 out of 10, okay? The pain may be poorly localized, and they may have some palpable stool, but usually otherwise no masses. So where's palpable stool on a physical exam? Same spot that diverticulitis lies, okay? The left kind of mid to lower quadrant. All right. So functional abdominal pain, there's going to be no red flags, right? We want to do a good history and physical exam. We're going to give them some education and assurance. We want these children to increase their vegetable intake and increase their water intake, and we'll just kind of watch them, all right? So vital signs, again, are vital. That's the whole point of this, right? We need to watch those vital signs, and we need to watch these growth charts to make sure this child is not all of a sudden falling off a growth chart. We can treat if we can find constipation, if we find some dyspepsia, there's some sort of a social phobia or some symptoms of irritable bowel syndrome, we can try to treat that. And then we should always be willing to reevaluate these children so that they have good follow-up. So it's like, okay, well, here's the things we're going to try. It might or might not work. Here's the reasons you should go to the ER. And then here are some medications to try, and we'll follow up in a week. What do you do if this is a female with abdominal pain? So it depends on age, but yes, pregnancy test and a urinalysis, always. Every female with abdominal pain gets a urinalysis. All right, so red flag symptoms, localized pain. So pain that's just in one location, it's not global pain. Weight loss, pain that awakens them from sleep, obviously bilious vomiting or a GI bleed. If they have a fever, joint pain, a rash, urinary symptoms, or severe diarrhea with lethargy, abdominal distension. What's obstipation mean? It means constipation just for a long time. Family history of irritable bowel syndrome or some sort of other pelvic, what is a PUD? What is that? Peptic ulcer disease. Good. All right.
Could you describe what bilious vomit is?
Yeah, so it's kind of like this greenish vomit. It's gross. It's kind of like your bile in your stomach, except more green. Because like the biliary fluid is like a green kind of bile type fluid. Their physical exam should not basically go to the right upper or right lower quadrant. They should not have any deceleration of their growth. They should not have this abnormal posturing. What's an appy look like on your table? Yeah, they are laying on the table with their legs bent. I've never seen an appy lay with their legs straight out in front of them. There could be, if there's organomegaly or lymphadenopathy, that makes you more concerned. What lymph nodes are we palpating here? Inguinal lymph nodes.
That is a sign of guarding, right? The raised knees.
Yeah.
Yeah, for sure.
Yeah, appies they lay in the bed with their knees up. They never lay with their legs flat. If you see somebody with their legs like this laying flat out of the bed, that is not an appendicitis. They might be in the fetal position on their side, but they're curled up in a ball. But yeah, I can watch a 26-year-old appy roll back and go, oh yeah, that's an appy. Let's do this. Okay, there we go. And then we can look for scars, right? Always look at the abdomen of your patient, because if there's scarring on their abdomen, that is very consistent with some sort of intervention prior, which makes them more prone to those bad bowel obstructions, volvulus, any sort of problem down there, because they have scar tissue. Remember, the bowel is always going to peristalse. So if it reaches scar tissue, it gets hung up, it can cause a bowel obstruction or something like that. All right, let's move on. So what are the conditions that need urgent and usually surgical intervention? So pyloric stenosis is just like it sounds. You've got this stenotic pylorus, hypertrophy or narrowing of the tissue of the stomach to the duodenum. Okay. This is the pants really likes this: projectile vomiting, an olive-shaped mass, and a string sign on barium swallow. So those are your kind of buzzwords there. Hypochloremic metabolic acidosis. Yeah, forget that. Okay. That is not a distinguishing feature. Of course, it is a feature, but that can be seen in multiple other conditions. So your high yield stuff is projectile vomiting, an olive-shaped mass, and a string sign on barium swallow. The cool thing about that is those things actually differentiate pyloric stenosis from other things. If you get wrapped up in this metabolic, blah, blah, like whatever, man, that's going to be in a lot of things. Okay. That is not a distinguishing feature. Anybody that's vomiting is going to have hyperchloremic metabolic alkalosis, right? They're losing hydrogen ion by vomiting. Okay. And that's why they end up with this alkalosis.
Do we know why this pyloric stenosis happens?
I don't really know. I think it's probably just a physiologic thing, but you could look it up. It'd be interesting to know.
When they surgically remove it, how does their stomach keep all their the chyme and everything in?
I don't know. It's a good question.
Do they replace it with a valve or?
I don't know what they do. You guys should do a little research on that and get back to the class. All right. Midgut malrotation. Okay, so it's exactly what it sounds like. The midgut rotates. Not good. Okay, that's going to obviously cause an obstruction. So you've got this malrotation just beyond, probably somewhere in the duodenum, and you get basically backup. Okay.
There's a lesser form of volvulus.
It's basically a volvulus. It's just where it's at. They call it midgut malrotation. So it's these two terms could be used interchangeably, but in kids they talk about this midgut malrotation like it's a different thing. And I think it's probably because it's a pediatric congenital abnormality. See, so a volvulus is going to develop later in a normal person, but a midgut malrotation is actually an anatomical variant. So that's probably, but it basically is the same thing. So you can do some imaging. So this is the stomach full of contrast. And then just below the stomach, there's not actually a pyloric stenosis, but can you see this whole corkscrew here? So anyway, but right here, see this corkscrew? That's the midgut and it's malrotating. Okay, it's rotating more than it should be, and it's basically choking itself off. All right, there's your volvulus. So you were right on track. It's basically synonymous with the volvulus. So the bowel's twisting upon itself, right? The most common spot of a volvulus is the sigmoid colon. Okay, why? Why?
Pressure.
Where's the sigmoid colon live? Which side?
The left.
Left. Okay. So the sigmoid comes down to your anus and rectum, right? The sigmoid is that last portion of the colon there. Okay. There's not a lot of adhesions there, and there's not a lot of stuff in that spot. So there's just like a little bit more volume in that area, and it allows things to flip. So in other areas, there's more stuff. I know this is really technical, but there's more stuff keeping things in line, whereas the sigmoid can flip because there's not a lot of stuff down in the right lower or left lower quadrant. So they may have a distended tympanic membrane, right? A tympanic, not membrane, a tympanic abdomen, right? So you do that. That would be weird, right? Physical exam findings of the ear are so vast. All right, so the abdomen, you know, when you thump on it, it's going to be like a hollow drum in there, right? Because they basically just have this distended belly. Okay, you're going to see this kind of coffee bean sign. There's your buzzword. Okay, and you need emergent decompression. So they need to get in there with an endoscopy, actually a sigmoidoscopy, and basically straighten that back out. So that's going to be a GI referral, and GI will come do that, but we need to be able to at least think that that could be going on. Okay. Once these people have this, they break those adhesions around the sigmoid, and now it can freely twist. So good question for history is, have you ever had a history of volvulus? Because that is going to predispose them to a volvulus. What does it look like? Well, it looks just like a coffee bean. There's that coffee bean shape. Okay. And look, there's a coffee bean. So I don't lie. It really does look like a coffee bean. Okay. It looks like a huge, weird bowel. Okay. So if you see that, that patient is sick as stink. Okay. You're like, oh my God, I don't know what's wrong with this person, but there's really something wrong with this kid. Sick versus not sick. This is your diaphoretic sick kid that you're just like, I know something's wrong and I don't know what it is, but I'm going to find out. Meckles diverticulum. Okay. What's a Meckles? It's just this abnormal protrusion where the umbilicus was, okay? It's supposed to like die back to the regular bowel, and it doesn't for whatever reason. But the really weird thing about a Meckles is you get this kind of like diverticulum that pouches out, which is just like we talk about diverticulitis. It's just an outpouching of bowel. Well, a Meckles diverticulum has this really, okay, so when a baby is grown from a fetus to a whatever, a big baby, it's really weird. The pancreatic tissue starts in one location for embryology, and then that pancreatic tissue spreads out. Okay, and it should go away down here where the Meckles is, but it doesn't. It lives in there. So that's why there's pancreatic tissue in the Meckles diverticulum, because embryologically, which we don't do embryology, okay? The docs do. So some of this stuff you can actually explain through embryology, okay? And so anyway, as an embryo, those tissues are really close. And then as the embryo starts to get bigger, they spread apart. And this pancreatic tissue goes away in a normal developing infant. However, if you have an abnormality like the Meckles diverticulum, it does not go away. So some really smart guys, smarter than myself, decided that they could figure that out and that they could use that to test. Okay. And so we'll talk about that test in just a second. But what really is nice is this rule of twos for Meckles diverticulum. So it's usually about 2 years old that this presents. It's in 2% of the population. It's 2 feet from the proximal to ileocecal valve, and it's 2 inches in length. Okay. So lots of twos there. All right. How does it present? painless rectal bleeding, okay? So that's what your question's gonna look like, right? You got a child, painless rectal bleeding. It's a current jelly appearance. What do you think? I think I should do a Meckles scan, right? What's your first test of choice? Meckles scan, right? Okay. So what are you gonna do? Oh my goodness, you're gonna do a Meckles scan. What does the Meckles scan look for? Well, it looks for, oh, it's gastric tissue. Man, did I get that confused with something else? Ectopic gastric mucosa. My bad. So it's the same as the stomach, not the pancreas, but same concept, right? So it's gastric mucosa.
Wondering how the pancreas got out of it.
Yeah, it does happen in embryology. But it does. So gastric, right? Tissue down here. Okay, same concept, but I screwed it up because that's my job. Yep. So everything's the same. I just said pancreatic tissue, and it's actually gastric tissue. So when you do this Meckles scan with the 99 MTC, whatever that means, what it's going to do is those radioisotopes are going to find, probably my guess is low pH. They're going to find that acidic compartment and they're going to stick in there. So they stick in the stomach. You can see on this Meckles scan, the stomach's lit up. And then right down here, see that little protrusion? Right there. See that? That's a Meckles. Okay, you're not going to need to see one of these and know, but you need to know that that's the test of choice to differentiate a Meckles from anything else. Okay.